Hi all, good evening. We'll be starting with OPAT today, and for those of you who are regarding OPAT, now OPAT is a huge subject, and it's actually one of the easiest subjects which you can have because we have read it well in a video, and also because it gets repeated in a number of other subjects as well. It tends to coincide with a lot of other subjects. So that way you're not totally new to the subject. Okay, I'll try and be louder. I hope it's clear now. Yeah. Just a brief introduction on how. Okay. Too loud? Do you want me to lower the volume? Or it's fine. We can proceed with this. Yeah. All right. I'll just give a brief introduction for students who will be reading OPATs in the eve fresh for the new batch. It's voluminous, but it's easy. It's a nice subject, and about to read textbook or not to read textbook, for those of you belonging to this new batch, it's a good time to pick up your textbook. It is a good time, and you have your keynotes with you to help you know what is important and how many points you need to know with respect to a certain subject, right? So our presentation here that we have in the class is also very similar, or rather it is from the keynotes. So that way you will be familiar with. So please sit with the keynotes next to you. And also very important for all the new students is, I want all of you to maintain a 200-page long notebook. Okay, and this book sits with you, next to you in every class of ours. Okay, that's where all the extra points go in. That's where the points that you feel is too tough for you or new to you go in every time you're reading. And like I said, it's a good time to pick up the textbook. Schaeffer is a good book. Nivelle is a good book. Nothing lower than this, please. Stick to Schaeffer or Nivelle. Both are good books, and find the time to read them. Another important point that you have to do when you're reading OPAT for the first time is the 200-page long notebook that I have been talking of. The first 4 pages will be dedicated to inheritance patterns of diseases. That's the most important thing that goes into OPAT. Okay? You don't need to read entire Schaeffer, or you don't have to sit with Nivelle. If you did that, you would take a lot of time. Taking the time constraint that you have, alright, you have 23 subjects and you have 12 months to finish them. So that doesn't leave you with too much time for each subject. What you have to do is just give it a gross reading. Now if you pick up the topic that we are doing today, for example, developmental disorders, you sit in a class with a certain basic idea. It's not like you don't know oral pathology at all. Let's face it, OPAT is our subject. I call it, हम उस चीज को बचपन से पढ़ते आ रहे हैं, because we read it so often, right? So when you sit in the class, it's not like it's totally new. You know something about it, but you need to refresh what you have read. So what you do is attend the class. Okay, even if you're not able to read, no problem. For those of you who are interns and feel you have to go to college, you don't have the time to read, no issues. Sit in the class with the absolute blank head, also no problem. But be attentive in class. After we finish the class, you don't have tests coming up, so you have that 1 week with you. Pick up the textbook and read what we have taught you in class. So that way, the topic is not totally new, and you also know which is an important topic. We would be telling you in class which is important, which needs to be given importance to, so you know which is important. And again, when you read Schaeffer's, you don't mug up every line. Okay? It's not like every line is important. So as and when I take a certain topic, I'll tell you how you need to read it. And make sure you give some time to do MCQs as well. Okay? It's like if you have 1 week, by the time you come to the next class, try and do MCQs of that same topic. So when you're fresh, alright, that helps you understand what kind of MCQs are asked. So that makes you get into a habit. Okay, this is the habit you have to create for the whole year. We've been having queries of students asking how we use the whole year. The whole year is going to be a combination of textbook along with MCQ books. You cannot totally restrict to textbooks. You cannot totally restrict to MCQs. Sit in the class, grasp as much as you can. Okay, you get 50% knowledge by just sitting in a class. Without contributing, if you just sit and if you just listen with attention, you learn 50% of the subject. So the rest of the 50% effort from your side is to brush up important points. Sit with color pencils, highlighters, okay, but learn to mark important things. Don't end up making your shafer so colorful कि आपको बाद में print ही नहीं पता चले. And it's not like every line is important. You got to know to read between the lines and mark important things. Then once you have done that, when you pick up MCQ books, you get slightly familiarized with it. And things when you're doing MCQs which you feel are new, that's when you go back to the textbook again. Okay? So you have done textbook, you go to the MCQs, you have a doubt there, or there's a new topic, or something that you have not read, or you couldn't recollect, then just briefly go back to the textbook. That's how you keep your reading true. Alright? So let's get started. At any point, any of you have doubts, please ask. Okay? It might be elaborative, it might be new, so don't feel shy. Starting with developmental disorders, very important, easy topic, but a lot of importance to be given to. Micrognathia, you understand from the word itself. A lot of terms that we talk of in dentistry are very self-explanatory. If you can just understand the gist in the word, it makes it easy. Micro, small, gnathia, jaw. You actually divide, we can have a true micrognathia or you can have pseudo-micrognathia. True micrognathia is where the jaw is actually genetically small, where the actual problem lies with the jaw itself. So this true micrognathia can be divided into two types, where one is congenital and the other one is acquired. These terms are self-explanatory. Talking about true micrognathia, where will you find true micrognathia? You will have a lot of points over here, so it will need revision. You can just keep reading them often. For those of you going to college and need to read OPAT for the first time, carry your keynotes along with you, along with the textbook. Read a certain topic, and if you feel there's important something, start mentioning it in your keynotes itself. So that way, when you finish OPAT, your keynotes have been enhanced. So you at least avoid picking up textbook for every line. So that way you have a synopsis of the notes of the textbook, which is handy for you to carry around. True micrognathia is associated with congenital heart diseases, and another important, very important syndrome that it is associated with called the Pierre-Robin syndrome, which has been an MCQ. You see micrognathia in Pierre-Robin syndrome. We will also get to what the features of Pierre-Robin are later. There is, you will also find it with agenesis of condyle. Agenesis of condyle means in the TMJ, you do not have the condyle form. Agenesis, lack of formation. So this is lack of formation of the condyle. And it can also happen when the fetus hand during development goes on the jaws. So that possibly is putting a certain pressure, during which probably the jaw size has been restricted to smaller. These are the conditions where you will see true micrognathia. Yes. Coming to Pierre-Robin syndrome, like I said, all syndromes are very important. You have a definite source of MCQ from syndromes, and syndromes initially might feel too much of information for you to gather, but as and when you keep familiarizing yourself with these terms, at the end it becomes easy. So Pierre-Robin is a triad where you have three things. You have true mandibular micrognathia, which is a bird face appearance. Because of the jaw being small, it's got a very typical bird face appearance. It's a narrow, squeezed out face. Okay? And another thing that happens here is the tongue has a lower position here, which actually blocks the airway. And so the patency of the airway is lost because of the falling back of the tongue and cleft palate. These are the three features of Pierre-Robin syndrome. Very, very important. This falling back of the tongue is actually referred to as the glossoptosis. Bird face is also seen in Treacher-Collins syndrome. It's also seen, yes. So you will see a bird face in Treacher-Collins, you will also find it in Pierre-Robin syndrome. So the three features of Pierre-Robin is glossoptosis, cleft palate, and your micrognathia. Now, what is the whole physiology of how this happens? Now, because in Pierre-Robin syndrome, we were talking about how the tongue falls back, or rather the glossoptosis. How does that exactly happen? See, you have micrognathia. So you have a small jaw, alright? And during development, you know that the jaw growth, the tongue growth is all happening simultaneously. It's not like the tongue develops once and then around it the mandible develops. It's not like that. They are simultaneously developing. So each one influences the growth of each other, right? So what happens is, because of the small jaw, and it's preventing the normal descent of the tongue. So what happens over here is, during development of the palate, and when the two palatal shells are coming together and they're supposed to fuse, there's the tongue that comes off in between them. Okay, because of the tongue coming in between the two palatal shells, the palatal shells are not able to fuse, which results in cleft palate. That's one reason why cleft palate happens. Then also this tongue is not occupying the correct position there, so there's inadequate support, right? So the tongue starts falling down. There's a descent, it falls back. Now this blocks airway. Airway patency is not maintained, that results in respiratory distress. So that's the entire cycle of how the cleft palate and the glossoptosis happens. Now the bird face appearance, which is typical of mandibular micrognathia, is a very important MCQ. Just recollect and give a brief brush up of the topic, and just excuse me for 2 minutes please, I'll get back to you. So bird face is characteristic of your mandibular micrognathia. Where do you have, what happens if there is a maxillary micrognathia? Maxillary micrognathia is going to result in a concave profile. Now what do you mean by a concave profile? When it's going to be like this, alright? As in your nose, your the upper arch and the lower arch, alright? So that gives it a concave profile. Now the reason for this concave profile, it does not always necessarily mean a maxillary retrognathism. The reason could also be a mandibular prognathism. Okay, you just have to understand the difference over here. Now if your maxilla is small and your mandible is normal, you will still have a concave profile. Alright, but it's possible that the maxilla can be normal and the mandible is prognathic. That also results in concave profile. Are you guys able to follow me? Okay. So these are two things that you'll have to be a little familiar with. Easy ones, but yeah, something to pay attention to. Now let's go to macrognathia, where we talk of large jaws. Again, when it comes to macrognathia, you have true macrognathia and relative macrognathia, or the pseudo one. Okay, you have true and you have pseudo, or this is again called as the relative macrognathia. This is like true macrognathia is where there is actual enlargement or actual large jaw. While a pseudo again means where, like say if you have the maxillary pseudo macrognathia is where the jaw appears large, but in reality it is not. In relativity to the mandible, it appears large. Here, the instances that we have given example are true examples. This is true macrognathia that we are talking of. You will find it in 3 conditions. Paget's disease, acromegaly, liantiosis osseosa. This has again been an MCQ. And in Paget's disease, maxillary macrognathia or a large maxilla is a very important finding. It's a characteristic feature of Paget's disease. So these are conditions where you will find a true macrognathia. 3 conditions, let's recollect. We have Paget's disease, we have acromegaly, and we have liantiosis osseosa. And these patients, older patients of Paget's disease will keep coming back to the dentist complaining of dentures becoming tight. So that's an indication of the maxilla getting larger in size. Acromegaly is gigantism, so that's where you have a large jaw again. We'll now come to a term called as the facial hemihypertrophy. Hemihypertrophy, half side of the face, so which means one side of the face. Yes, liantiosis osseosa is also a Paget's disease. It's like a lion-like. Liantiosis osseosa, the previous term that we have seen over here, is an expression for a lion-like face. So it's trying to talk of large structures. It's huge, basically. Lion-like. Liantiosis means lion-like. Next topic of facial hemihypertrophy. Hemi, one side of the face. Hypertrophy, enlargement. So here we're talking of one side of the face being larger than the other side. So if you see here, the incidence can happen equally on right side and left side. There's no particular predilection that it happens only on the right or it happens only in the left. Yes, again it's the maxilla arch that will be involved in liantiosis. So an equal incidence, which is also an MCQ. And hemihypertrophy has been found to be associated with a neoplasm of the kidney, okay, which we call it as a Wilms tumor. We will be reading more about it probably in surgery or medicine. Now it has an association with neoplasm of the kidney, which is Wilms tumor, and also liver and adrenal cortex in children. So here what we are trying to assume is facial hemihypertrophy has an association with a lot of systemic conditions in the body. In these systemic conditions, what are the organs involved? We can have kidney. When it is involving kidney, an important syndrome or a tumor associated is Wilms tumor, and other organs like liver and adrenal cortex. Okay. Then you also have mental deficiency in these patients. So just 3 points that you have to remember. So for those of you who are new, you would have figured out by now, you don't have to by heart every line of Schaeffer or Newell. Alright? So when you just pick up an important topic, very, very important in oral pathology is the other names, synonyms of the topic. We will be coming across many other names, that's important. So concentrate on that, highlight those. You will have the names in brackets just below the main name. And apart from that, incidence. Incidence as in gender predilection, whether it's involving the males or females. That's an important criteria. In a lot of diseases, which sex is involved itself can be diagnostic. Again, not for all diseases, for important ones. Then again, if it's having a maxillary predilection or a mandibular predilection. And important clinical features about it. Sometimes when you go to histological feature, there may just be one important term in the whole histological paragraph that you have to know. So important points like that, you'll have to make a note of in the text. We have a lot of malformation syndromes associated with hemihyperplasia, and there has been question on this. I just want you to get familiarized with a few syndromes. This is not there in your book, so if you can make a quick note of it, it's not like you have to by heart this whole chart that I have put up here. It's just for an information for you to just familiarize with the terms. Okay? We have something called as Proteus syndrome, which has been asked previously in All India exams. Now here I am talking about syndromes that are associated with hemihyperplasia. Remember, we are talking about facial hemihyperplasia. And so we have Proteus syndrome, we have McKeown-Albright syndrome, Okay, so let's go back, giving you the important names. McKeown-Albright, Proteus, Beckwith-Meadman, neurofibromatosis, Maffucci syndrome. I've somewhere come across Maffucci syndrome, so that's again I just wanted to get familiar. So these are syndromes associated with hemihyperplasia. If you guys can just make a quick note of these things in your keynotes, please. Still voice lag? Okay. Now y'all could write down. Can I change the slide? Coming to hemiatrophy. Now what we've covered previously was a hypertrophy. We'll now do atrophy when one side is actually shrunk. Facial hemiatrophy, like I was telling you previously, you have a lot of other names which are important, synonyms. So also called as Paraoral syndrome, MCQ. Throughout our classes, we give you important MCQs that have been asked previously. So these are things that I want you all to instantly recollect immediately. Alright? So when I say MCQ and mark it as Q, it's for you to take it as you have to know it. So Paraoral syndrome, facial hemiatrophy, also called as Romberg syndrome. And here the incidence on the left side is greater than the right side of the face, which is again an MCQ, and it could be an important diagnostic feature here. With left side having greater indications, like you have MCQ questions based on there is a patient who has left side of the face being more atrophic than the right side of the face, and what is it indicative of? You can have MCQs like that. To compare with facial hemihypertrophy, which had an equal incidence from the left and the right. Here left is greater than right. You'll see that in atrophy you will have a white line. The initial lesion that you will see is going to be a white line or a furrow, okay, on the affected side. And all facial tissues, including the roots of the teeth on the same side, will also be affected. So you will actually have small teeth in these people on the affected side. Clear so far? Any doubts? Coming to van der Waals syndrome, you will be having a lot of syndromes over here. New students, don't get demotivated and don't feel yaar so much to study. No. इससे ज़्यादा है पढ़ने को, so brain has a lot of capacity. So give your brain enough chance to take in whatever it can. With lot of revision, it's Easy. In hemihypertrophy, both sides are equal. Yes. Right side and left side can be equally affected. There is no particular predilection of sides. While in atrophy, there has been a greater occurrence of the disease on the left hand side than on the right hand side. Is scleroderma associated with Paraoral? Okay. That's something I'll have to check. Well, we could, hello, can you hear me? Yeah, yes, about the presence of scleroderma and Paraoral, we'll have to check. We could keep that as an assignment for next class. Okay, we'll go to van der Waals syndrome. There are three things again in van der Waals syndrome. There is pits of the lower lip with cleft lip, cleft palate. That's the easiest syndrome you can remember. Pits of the lower lip, cleft lip, cleft palate. Three things here. Again, MCQs do come from here. Then we have another thing called as Usher syndrome. Usher syndrome has three conditions again. This has been an MCQ again, easy one. Double lip, blepharochelatsis. We have a diagram, so don't worry about that. What is blepharochelatsis? Big word, but it's just a drooping of the skin between the eyebrow and eyelid, and non-toxic thyroid enlargement. Okay, so everybody's telling you it's all double. You have double features. Okay, so we have a dropping of the skin between the eyebrow and the eyelid, and non-toxic thyroid enlargement, and double lip. All double, huh? Double eyelid, double neck. Okay, so you can see the diagram. You can see the eyelid. Okay, there's actually, if you see the reason, it's dropping of the skin between the eyebrow and the eyelid. All of you can look into this diagram. This is blepharochelatsis, right? Double lips. All clear in the diagram? You can see the double lip actually forming a cupid's bow there. So which syndrome are we talking about here? Blepharochelatsis, double lip, Usher syndrome. And what's the third feature? We've seen double lip, we have seen drooping of the eyelid, which is blepharochelatsis. So this is one feature, this is the second feature, and what is the third one? Just a brief brush up for you guys. Yes, we have the non-toxic thyroid enlargement. Okay, next we come to cleft lip, cleft palate. Cleft lip, cleft palate again is going to be covered in a number of subjects. So here I have restricted it to knowing it only to OPAC, not taking into account your treatment part over here, okay? The occurrence of it, important MCQ. 1 in every 800 newborn. This is again a global incidence. Let me make this very clear. We are talking about a worldwide incidence of cleft lip, cleft palate here, which is 1 in 800. This has been asked as an MCQ, so please be clear on it. The frequency of it, with or without cleft palate. So you will frequently see this as CL plus or minus CP as 1:800. And yeah, it has a higher predilection in India, but you know, about 1:1000. You cannot give that. At least what I found recently is they have different incidents in different parts of India, and again it's different for cleft lip and different for cleft palate. Anyways, I haven't seen any MCQ on the incidence in India. It's always been 1:800 globally. Of course, if they specifically ask India, you will have a higher predilection, okay, but it cannot be summarized to cleft lip alone or cleft palate alone, because then the values are again different for each of these. Within India, that is different. Like it's different in north, it's different in south. The most common etiology of cleft lip, cleft palate is hereditary. And again, see, when we talk of mode of inheritance of a disease, when we talk about genetic sequence, we read it as an autosomal dominant disorder, autosomal recessive, X-linked dominant, or X-linked recessive. Right? These are the different ways of pattern of inheritance that we read. But when it comes to cleft lip, cleft palate, it's called as a polygenic disorder. You have a number of causes that contribute to it, so it's actually polygenic. You want me to write that? Has a multifactorial incidence, so you cannot say this one particular thing is the reason for it. Then cleft lip, will take isolated cleft lip over here and classify it. You have, it can be unilateral, it can be bilateral, it can be complete or it can be incomplete. Okay, I'm assuming all of you have attended an embryology class recently. Okay, so you all can tell me what is, I left this question intentionally because I want to know what lack of fusion results in cleft lip. I'll repeat my question. Basically I want to know what is the genetic defect in cleft lip. When we talk of fusion, we have a lot of processes that fuse that result in cleft lip, a lip formation. So what fails to fuse in cleft lip? Maxillary process with median nasal process. All agree with that? So this is a lack of fusion of I will also be sticking to the short form, can't write all of it, so I'll be sticking with MP for maxillary process and median nasal process will be MNP, okay? So it's a lack of fusion of this which results in cleft lip formation. So now when this is incomplete, we'll call it unilateral incomplete. Accordingly, you can have a bilateral complete. And there is a specific term you must have read for bilateral complete. What is another name for a bilateral complete cleft lip? Hair lip. Okay, since all of you are aware of this, I think I'll just proceed. But make a note of this cleft lip classification, and when it comes to the most common type of cleft lip, it is a unilateral complete, which is the most common type. Okay? Next, about cleft lip and cleft palate occurring together. Hair lip we have already seen, it's maxillary bilateral cleft lip. And incidence, let's look at the incidence patterns over here. We have cleft lip and cleft palate, where that is when cleft lip along with cleft palate, when they happen together, that is more common in the boys. MCQ. Has been asked many times. You have to be familiar with this. Isolated cleft palate is common in females. MCQ again. Okay? Can you all follow me? You can have cleft lip isolated. You can have a cleft palate which is isolated, where a patient has only cleft palate and a patient has only cleft lip. There are also conditions where patients can have a cleft palate along with cleft lip. That kind of incidence, where a patient has both cleft lip and cleft palate, is more commonly seen in the boys. And isolated cleft palate more common in females, again another MCQ. Cleft of the lip is 3 times more frequently seen on the left side. We have MCQ again. There was something else that we saw on the left side more common. What was that? Can all of you hear me? Yeah, we had seen hemiatrophy to be more common on the left hand side, which we also called as the Paraoral. Now we have one more thing that's more common on the left side. So that is your cleft lip. Make a box. Make a box in your notes that I asked you to put conditions which are common on the left side. So we already have 2 in that list, where we have isolated cleft lip and Paraoral syndrome. The maxillary cleft ridge usually appears in the region between the lateral incisor and the canine. Yeah, in 70% of the cases you can see cleft lip on the left hand side. The incidence of the places where you will find this cleft lip is between your lateral incisor and canine. Again, this is an MCQ. We have a syndrome which has been found to be associated with your cleft lip and cleft palate. It's a median cleft face syndrome, a cleft of the entire face. Okay, finds an association with cleft palate. So that's why we read it here. The features of this cleft face syndrome are hyperthyroidism, bifidum occultum, and cleft of the premaxilla and the palate. Hyperthyroidism means when there is an increased distance between the eyes. Okay, that will be a hyperthyroidism. And cleft of the maxilla and palate. So this is again important point here. All going okay? Yes. Isn't that next we'll read Fordyce's granules. This has also been an important MCQ. You'll find a lot of MCQs with respect to they are asking you yellow spots seen on the mucosal aspect of the cheek. You find that question frequently being asked. So that's Fordyce's granules. How do they clinically appear? They appear clinically as yellow spots. A frequent site for it is the buccal mucosa. Okay, so it's on the cheeks. Opposite the molar teeth, so it's more in the molar region. So these are important points about it, with which you'll be able to come with the answer as Fordyce's granules. What are Fordyce's granules actually? They are a collection of sebaceous glands in the oral cavity. Another thing is they have a bilateral symmetry. MCQ here. So Fordyce's granules, important points is they are sebaceous glands in the oral cavity which appear as yellow spots. It's usually seen bilaterally opposite the molar teeth. You have a diagram. I'm not sure how well you can appreciate the yellow spots here. Are all of you able to see this picture? Okay. So you can see these yellow spots, that's how they will appear. And the histological diagram of how the sebaceous glands appear histologically. Next we come to Hex disease. Hex disease, another name of it is important. Focal epithelial hyperplasia. This has also been an MCQ. What the other name of Hex disease is? Let's recollect again. Hex disease, focal epithelial hyperplasia. Alright? And this disease has been found to be associated or rather caused by, the etiology is believed to be a virus. Okay? And the virus associated is the HPV virus, the human papilloma virus. This is also an MCQ. How does the lesion appear? The lesion basically has papillae. It's a papillary lesion found on the labial, buccal and lingual mucosa. And you will have a lot of papules here and there. Okay. Sometimes what can happen is that these papules can come close together and cluster together. So that makes it a larger lesion, and to touch, alright, to basically touch the surface, it gives it a cobblestone or a fissured appearance. MCQ. Get into the habit of making small post-its or these sticky notes basically. You have a lot of post-its, I know it's going to be expensive to buy them, but those of you who have parents, cousins, sisters, brothers going to offices who get free post-its, ask them to get them for you. I used to do that. It's a nice thing to do. Husbands, cousins, brothers, sisters going to offices. I'm not encouraging robbery. I'm not encouraging, all software engineers. Please don't tell Bhavana ma'am encourages theft from software offices. Well, I'm not encouraging that. If they're not using it in their offices, and for those who get a supply from their office but are not using it, people like you who will actually use it, it makes sense. Right. So collect it from them. Start making nice post-its where you put, like for example, you in that just mention Hex disease, HPV associated, cobblestone appearance, and just start putting it on your wall or even in your keynotes for that matter. So that way you have the most important points being highlighted, and you can also do this for things that you keep forgetting. Let's say there's a syndrome you can't remember. There are so many syndromes and finally it becomes a khichdi. You can't remember for some time at least, or you make it in pencil, which you feel initially is difficult for you to read, but in the long run, yes, you will remember, so that you can erase and reuse. That way you say paper rolls. But try everything you can that will help you understand and remember better. See, it's not about remembering today. आज का पढ़ा हुआ आज definitely याद रहेगा. एक हफ्ते तक, yes, you will remember. But every time you read, your effort should be to make sure what you read is remembered for a long duration. It's not like you read today and you tell कि यार आज नहीं याद हो रहा है, आज छोड़ देते हैं. पेपर के पहले पढ़ेंगे ना, पेपर तो जैन में शुरू हो रहा है, तब पढ़ेंगे. तब पढ़ने के लिए you'll have more things. So don't postpone things. Okay, every time you read like this is the last time you're reading. And make every effort to try and remember it for a long time. Cobblestone seen somewhere else? Yes, we will come to that. Hint, I think one of the skin disorders. Not sure if that's right. But I think one of the skin diseases. We're getting a lot of answers. Take it as an assignment for today. Let's find out where else you see cobblestone appearance. This is for you guys. Exam going. Okay? Yeah. Refresh your mind. There are a lot of things. now what happened for the exam going students is like दिमाग में बहुत कुछ है, इधर उधर फैला हुआ है. You've got to cluster it together. Now cheilitis glandularis. Now this is a condition that's basically associated with your lower lip. Most frequently lower lip gets affected, and what happens to the lip becomes large, enlarged, and becomes everted. So here, no. I know there are two terms. You have cheilitis glandularis and you have cheilitis granulomatosa. Okay. If you take the word itself, it's easy. Now, the words itself are very self-explanatory. Cheilitis means it has to do something with the lip. Okay. So we know we're talking about lip. Glandularis, glands related to the glands. So let's take it as the enlargement of the glands. So it has to do with the lip and the glands. And what's happening over here is because of the enlargement, your lip becomes huge. And finally becomes everted. Everted means pops out like that. Pop out as in pura pop out nahi, but it gets out enlarged. Then there is a classification of glandularis where you have three types. This classification and the other names of this classification is important. Farmer's lip. No, I don't think so. This is farmer's lip. Little doubtful of that, Priyanshu. What now? The three types. Let's get to the three types of cheilitis glandularis. The simple one, which is the most common one, MCQ again. The most common type of cheilitis glandularis is the simple one. Yeah. Then we have superficial suppurative. Pay attention to these terms, please. You have two suppurative. Okay, you have superficial suppurative and you have deep suppurative. Superficial suppurative is also called as Beale's disease. Very important MCQ. Okay. Then we have deep suppurative, which is called as myxadenitis labialis, also called as cheilitis glandularis apostematosa. Big name, I know, but big name is the deeper one. Okay. Beale's disease, small one, superficial suppurative. Superficial is small. Deep one is long name. And your myxadenitis labialis is also this deep suppurative one. Now this lesion is believed to be pre-malignant, which means, what do you understand by the term pre-malignant? Conditions which have higher chances of turning into a malignant lesion. Okay. On a specific stimulus is called as a pre-malignant lesion. Now this is believed to be pre-malignant, and these disease can get transformed into a malignancy. Okay. So glandularis has three types. Now cheilitis granulomatosa. Like I said, it's easy to distinguish between the two names itself. When we talk about cheilitis granulomatosa, it is a granulomatous inflammation. It's basically a chronic inflammatory disorder. This is again also affecting the lower lip. When it comes to lip, both of them are affecting the lower lip, but the etiology is different. Here, it's a chronic granulomatous inflammation. And the other name for cheilitis granulomatosa is Mishra's syndrome, which is also an MCQ. Okay, so let's go back. Just a brief brush up. Beale's disease was, what was Beale's disease? Superficial, yes. Superficial what? Cheilitis granulomatosa, cheilitis glandularis. Superficial, suppurative cheilitis glandularis. Yes, that was Beale's disease. Here we have Nisha syndrome, which is cheilitis granulomatosa. And it also has, it's painless is another important point. You have questions in your MCQs on which is a painful lesion, which is a painless lesion, so sometimes remembering painless, painful is also important. It also has an association with a syndrome called as your Melkersson-Rosenthal syndrome. Important syndrome here again. So this is associated with scrotal tongue, facial paralysis and cheilitis granulomatosa. So that's clear? And about farmer's lip, it's also called as the sailor's lip. It's associated with basically actinic cheilitis, sunburn. Now, let's go to hips. Hips, wondering what hips? Not our hips. Hereditary intestinal polyposis syndrome. Yep. Yeah, we refer to this as hips actually. Hereditary intestinal polyposis, also called as your Peutz-Jeghers syndrome, it's an autosomal dominant disorder. Now remember I told you, you have to dedicate the first 4 pages of your point book, your 200 pages long notebook which I asked you to maintain, and dedicate the first 4 pages. 1 page goes for autosomal dominant, next page for autosomal recessive, next for X-linked dominant, and 4th for X-linked recessive, and 1 page dedicated to multifactorial. Like for example, later on you will go to maternal, mitochondrial, paternal, and just keep 1 page extra. Okay. Now this list, your hips goes to autosomal dominant. Alright. Now I told you keep an extra page. Like for example, put your cleft lip, cleft palate there as being polygenic or multifactorial. Okay. And now this is something that all of you have to make an effort and start filling in these pages. It seems painful in the beginning. But if you put this effort for the whole year, it makes it very easy when you sit up for an exam. Okay, now you're doing individual subject wise. But when you go close to exams, you might have to do more than 1 or 2 subjects in a day. So then you cannot sit with pulse and say, let me do OPATs today, let me do oral surgery tomorrow. You don't really have that much time. So when you have all the disorders and its inheritance patterns put together in 1 book, let's say you just have 1 hour, okay, and you don't want to waste your time, pick up this and read all that, because inheritance pattern is a very important MCQ. I can guarantee you all India will have 1 question from inheritance patterns. Definitely. Guaranteed on that. Which disease I can't tell you, okay? But there will be 1 inheritance pattern for sure. And you can't see from where it comes. Initially when you're reading, when you read developmental disorders, it feels, come on man, barely 5 or 10 diseases, like I can't remember it. Autosomal dominant is dentinogenesis imperfecta, amelogenesis imperfecta, hips, yes, it feels okay. When you finish pura oral path, then you would have prayed ki, oh shit, maybe I should have started writing. So don't postpone it. It's easy to jot down things when it is topic wise. It's difficult to sit with full Schaefer and say today I am going to make a note of all the inheritance pattern. It's not possible. You can't sit with it and do it in a day. It happens over a period of time. So you have to do it on a daily basis while you're reading oral pathology. So today you start maintaining this book, and as and when you start mentioning these diseases under that. And if you honestly mention all the diseases that we need to know, you will get 2 pages long of autosomal dominant, 1 page full of autosomal recessive, half a page for X-linked dominant and half a page for X-linked recessive. That is if you sincerely do it. And I can say that guarantee because I have done it. Yeah? Okay. So let's get to hereditary intestinal polyposis, which is an autosomal dominant disorder which has to go into your list. What are the features of this? It's familial generalized intestinal polyposis. Intestinal polyposis is important. It's restricted to the colon and the small intestine. It's usually the small intestine. And I think this has been an MCQ, not in OPATH, but in general medicine. Which part of the intestine it's restricted to? Small intestine, mostly jejunum. So that's an important part. And apart from intestinal polyps, polyposis means presence of a lot of polyps. And apart from it, you will see pigmentation, melanin pigmentation. This is seen on the face and oral cavity, and the distribution in the oral cavity, or rather on the face, has more on the perioral, that's in and around the oral cavity and around the nose. So the distribution of the pigmentation is referred to as the perioral and perinasal. This has also been an MCQ. The MCQ has been, what is the kind of distribution of pigmentation in Peutz-Jeghers syndrome? It's perioral, perinasal on the face. You could also see it on the hands and feet. Pigmentation, I've already told you that. These places again in the oral cavity where mucous pigmentation is common is first buccal labial mucosa, gingiva and hard palate, and least pigmentation is seen in the tongue. Facial pigmentation, another important point is this is again an MCQ, that when it comes to Peutz-Jeghers syndrome, you have pigmentation out on the face, so which makes it extraoral. You also have pigmentation intraorally. Intraorally we have seen it's more so on the buccal mucosa and the labial mucosa, and least pigmentation seen on the tongue. Now this pigmentation on the face tends to fade away, but the mucosal pigmentation will stay. There is no fading of the mucosal pigmentation, which is important MCQ. Most pigmentation is labial buccal mucosa. Highest amount of pigmentation on the buccal and the labial mucosa, followed by the gingiva and the palate, least in tongue. Most and least is also important MCQs. So wherever you find in our notes or in our presentation, most common will be MCQs again. This is inherited as a dominant pattern, Mendelian dominant. We've seen this. It's not sex-linked. Also seen this. Then coming to a term called retrocuspid papilla. This is just like seen in the lingual mucosa, mandibular, near the mandibular cuspid. This has been asked in perio as well. It's an important point. Talking about the mandibular canine, and near the mandibular canine, if you observe near the lingual mucosa, you will find a slight elevation over there. You will find a small papilla there. Okay, that's called as the retrocuspid papilla. An important MCQ in perio. Then we will read about macroglossia. Macroglossia means large tongue. Okay. Doesn't necessarily mean people with large tongue talk more. Yeah. People commonly referring to saying jeeb lambi ho gayi hai because they're talking more. Nah, it doesn't work. Okay. So we again, when it comes to a large tongue, it can be primary or it can be secondary. Primary means it's a congenital disorder. Now you have a lot of syndromes that is congenital, which are associated with macroglossia. I have a small chart for you that you can go back and refer with. And secondary conditions where you see macroglossia means anything that is secondary means the basic problem is not with the tongue. You will be coming across these terms primary and secondary in future, so you have to understand what they mean. Primary means the primary problem. I'll tell you with respect to macroglossia what it means. Primary means the actual problem lies with the tongue, but the actual problem is an enlarged tongue. That's a primary condition. A secondary means the primary problem is something else and your macroglossia is one of those symptoms. So which makes the macroglossia a secondary problem. Okay, that's what secondary means. Secondary again is a long list of conditions and you have to be familiar with all of them. There have been MCQs on this as well. So you will find it with lymphangioma, hemangioma, acromegaly, cretinism, congenital hypothyroidism. These are conditions where the tongue may be enlarged, secondary reasons. How do you identify clinically a macroglossia? A patient with macroglossia comes to you. How will you identify that this patient has got a large tongue? Crenations on the tongue. MCQ. People who have a large tongue, it's obvious that it's going to come in between their teeth, right? So you will see tooth marks or crenations on the lateral borders of the tongue. That is how you will identify clinically a person with a large tongue. So that's an important point. Do you guys think I talk more? Just off track. On a simple, on a normal, yeah, no, actually, okay, people who know me do call me very talkative. I'll tell you why. When I went for a normal checkup, my dentist identified crenations on the lateral border and he said, you have a big tongue. My mom was present there and she said, no wonder why she talks so much. I said, no, people who have large tongue doesn't mean they talk too much. I do talk too much and I also have a large tongue, but they actually don't go together. It's not very large, okay? Abnormally nahi. Comparatively thoda bada hai. Cause I don't know. It's not abnormally large, but slightly larger than normal. So there are some. The dentist did find some crenations on the lateral borders. Pata nahi kyun. But I don't have any problems. No macroglossia associated problems for me. Let's look at the long list of causes of macroglossia here. Like we said, no, it can't be because of a lot of teeth. Actually, well, let's not get into my case history now. Let's get back to causes of macroglossia. We can have it congenital and hereditary. We have already discussed lymphangioma, hemangioma. Now these two have been MCQs. They are when this condition is found, it most commonly affects the tongue. So tongue is the commonest site for lymphangioma and hemangioma. So it's a very important MCQ. The avascular malformations, most common cause for causing macroglossia of the tongue. Cretinism, then Beckwith-Wiedemann syndrome, very important MCQ and common finding of macroglossia. Down syndrome, again, Down syndrome, everything related to the Down syndrome can be an MCQ. So for those of you reading for the first time or reading for the nth time, please be familiar everything about Down syndrome. There are a lot of questions about Down syndrome and you can find this chart from Newell. If you want to make a note of, you could find it in Newell. Mucopolysaccharidosis, neurofibromatoma, multiple endocrine, that's your MEN syndrome. Those are congenital conditions which find macroglossia. Acquired is in edentulous patients, amyloidosis, myxedema, acromegaly, angioedema and carcinoma. You know, for all of you who are reading for the first time, you need to by heart this chart. But when you finish reading a lot of subjects, you find it very relative. When you read amyloidosis, you'll understand why the patient has a large tongue. When you go to thyroid conditions and you read about myxedema, you understand why they have a large tongue. So then there isn't really the necessity to sit up and by heart. You get the relativity of things, you can start putting things in place. A lot of these conditions you will feel like you'll by heart it now, but when you finally finish reading a couple of subjects, there's no necessity to by heart. When the question comes, you know in the MCQ that this is associated with a large tongue. But for now, an important chart. Now macroglossia again can be true or it can be pseudo-macroglossia. And this is the information that I found new in Schaeffer's in 6th edition, which is not there in your 5th edition. So I felt new topics are usually a source of MCQ. I found this to be new in Schaeffer's 6th edition. So all of you can just concentrate on this bit a little. What do you mean by pseudo-macroglossia is other conditions, okay, other than genetic, okay, other conditions which force the tongue to occupy an abnormal position. If I can have all your concentration back on the slide, please. Pseudo-macroglossia means conditions other than the congenital conditions which result in the tongue occupying an abnormal position. That's pseudo-macroglossia. Okay, so where the size of the tongue may be normal, okay, but there are a lot of other reasons which make it appear large and which compromises function as well. So these patients with pseudo-macroglossia have compromised function. Conditions where pseudo-macroglossia is seen is habitual posture, enlarged tonsils, low palate, decreased oral cavity volume, and deficiency between the maxillary and mandibular, any kind, be it transverse, vertical or anterior posterior, which displaces the tongue. Yeah, it can be. In pure organs, yes, you can be talking of pseudo-macroglossia. Severe mandibular deficiency, some neoplasms and hypotonias. So these are conditions where you see pseudo-macroglossia. Any doubt here? Next, Beckwith's hypoglycemic syndrome. This is the condition where you have macroglossia. Apart from that, you have neonatal hypoglycemia, mild microcephaly, umbilical hernia, fetal visceromegaly, and postnatal somatic gigantism. MCQs do come from here. So just go back and at the end of the class today, sit up with your keynotes, all the syndromes go through once, put all the inheritance patterns and go through that once, then maybe you can pick up the textbook tomorrow to go back and read. Then we come to bifid tongue. Bifid tongue is actually a cleft tongue. Okay, doesn't mean two tongues. There is a cleft in the tongue. I think I have a diagram. No, I don't have. Okay, it's like just a cleft in the tongue which feels like it's bifurcated the tongue. But it doesn't necessarily mean it's two tongues. Okay, that's your bifid tongue. Then we have a condition called orofacial digital syndrome. There is an MCQ on this as well, which shows the presence of this bifid tongue. So what do we have in orofacial digital syndrome? Bifid tongue. You have fibrous bands in the mucobuccal fold. You have a cleft and hypoplastic alveolar process. So this is again a double condition. Bifid tongue, a cleft of the alveolar process, and fibrous bands in the anterior, that is in the mandible. In the mandible there is mucobuccal fold, fibrous bands. That's orofacial digital syndrome. Coming to fissured tongue, also called as scrotal tongue, other name again important over here. You have a classification for this, that is, it's divided into foliaceous, cerebriform and transverse. This is how all of you can see in the diagram. That's how a fissured tongue will look. You can see all these fissures over here, right? All of you can observe those fissures there. Where else do you find fissured tongue? And this is again not in your keynotes, so if all of you can just make a quick mention of these 3 points there. Where do you find fissured tongue? It's found in Melkerson-Rosenthal syndrome, Down syndrome and in benign migratory glossitis. 3 conditions where you will find fissured tongue, which has been asked as MCQ. Let's recollect. Fissured tongue is seen in Melkerson-Rosenthal syndrome, Down's syndrome, benign migratory glossitis. Clear? And we've already seen what Melkerson-Rosenthal has. It's a triad of fissured tongue, cheilitis granulomatosa. What is the other name of cheilitis granulomatosa? Other name of cheilitis granulomatosa? Miescher's syndrome. And it's associated with Bell's palsy, that is the 7th nerve paralysis. Coming to median rhomboid glossitis. For this, I need you to briefly recollect how the tongue is formed. When it comes to formation of the tongue, we read about, I'm not going to be getting into the details because you've freshly attended an embryology class, but just to recollect, you have 2 lateral swellings and 1 tuberculum impar. Right? Okay. So there has to be fusion of the 2 lingual swellings, and that is your lateral swellings, and 1 tuberculum impar, and that will actually result in the formation of your tongue. Now, what happens, like I said, all these 3 structures fuse. Okay? Etiology for median rhomboid glossitis is when the tuberculum impar fails to retract before the fusion of the lateral halves. So there is fusion of the lateral halves first, and then there is fusion with the tuberculum impar. And for that, what should happen is there is some amount of retraction that the tuberculum impar should do, so that the 2 lingual swellings can fuse first. But when that doesn't happen, so which means what? There is some amount of this tuberculum impar that is getting in between these 2 lateral swellings. So it's getting retained over there. That results in a median rhomboid glossitis. So how does this clinically appear? Your tongue, in the posterior part of the tongue, you will see a diamond colored or a rhomboid colored red shaped area. That is how it would appear clinically. It's also called as central papillary atrophy of the tongue. Now it appears red, so that part of the tongue is atrophic. So that is why it's red. Okay? And they have found that it could probably be because of fungal cause also. So they have found an association with Candida albicans as well, and this is also your MCQ. Association with fungus, Candida, is also an MCQ. Median rhomboid glossitis, more common in women, has a greater predilection in women than in men in a ratio of 4:1. And this point that I want you to make a note of in the keynotes, that it is commonly referred to as kissing lesion. Please don't get confused between kissing disease and kissing lesion. This is called as kissing lesion. We have another term that's called as kissing disease. Kissing disease is infectious mononucleosis, a disease that is affecting the vascular system, and this disease is caused by the EB virus. EB stands for Epstein-Barr virus. So kissing disease is a blood disorder caused by EBV, and it's infectious mononucleosis. So that is kissing disease. Now we call median rhomboid glossitis as kissing lesion. Why kissing lesion? Can you be a little imaginative? I hope all of you have got a little diagram of how the median rhomboid glossitis appears in the tongue. Okay, that part of the tongue is in contact with the palate, right? Okay, so the part of the tongue which contacts the palate, you will also see infection in the palate. Actually, this disease is of the tongue, right? So if you're expecting infection or if you're expecting the lesion, you will expect it to be restricted to the tongue. But what is happening here is the area where there is lesion, okay, where there is median rhomboid glossitis, that part of the tongue is coming in contact with the palate above, and the region where it is touching, that part of the palate has infection. So that has happened because of contact between the tongue and the palate. That is why it's called as kissing lesion. Okay? That was about median rhomboid glossitis. We have another term here called as benign migratory glossitis. Okay? The other names of benign migratory glossitis is very important, and you have a long list of names. It's also called as geographic tongue, also called as wandering rash of the tongue, glossitis areata exploitativa, and erythema migrans. And trust me, all of it has been asked. Erythema migrans has come, wandering rash has come, geographic tongue, and all three of them have been asked as MCQ. So familiarize with the names. Why is it called so? Why wandering rash? Why erythema migrans? Erythema migrans is so obvious, the term. Erythema, redness. Migrans because it keeps migrating. It's never found in one place. Median rhomboid glossitis is always found in the midline. It is always found in the posterior third of the tongue, and the shape is always diamond. Okay, you can say that. But you cannot say so for benign migratory glossitis. If it happens in the lateral borders, it can happen on the dorsum. If it happens in the posterior dorsum, it can later on migrate to the anterior part. It's a migrating lesion. It can happen anywhere in the tongue. That is why it is called as the wandering rash of the tongue, or the geographic tongue, because it can happen anywhere across the dorsum of the tongue. And what happens basically over here is there is some amount of loss of papillae. The papillae that are lost is filiform papillae, again an MCQ. Which papillae is found to be lost here is your filiform papillae. And if you have a look at the lesion, I think I have a diagram for this. No, sorry, I don't have a diagram. Let's draw it. Okay, just to give you a rough idea how this look like, there will be a central red, okay, a central red lesion, which is characterized by absence of the papillae, because of which it appears smooth and it appears flat, smooth, flat, red lesion because of the absence of the papillae. Surrounding this red rash is going to be a small yellow colored border. Okay, there will be this yellowish border around it. That is how these lesions appear, and they just keep changing their place, just keep changing positions. If it's found once here, it would be found elsewhere here, and from here it could move there, and that's how these usually happen. Yeah, important for you is this filiform papillae that are lost, and it also has a psoriasiform. It is a psoriasiform mucositis. Now there is this term called psoriasiform that I want you to get familiarized with. Not there in your keynotes, so please make a mention of it. What do you mean by psoriasiform? Like psoriasis. That's what it means. Like psoriasis. Now, when it comes to what is included in the psoriasiform lesions, we have three conditions which come under psoriasiform. First is your benign migratory glossitis. Contribute, people. What are the other psoriasiform lesions? Benign migratory glossitis is one. Okay, I was asking you all a question on what are the other lesions that come under psoriasiform lesions. One is benign migratory glossitis, psoriasis, and then and Rita's syndrome. I hope all of you got it. Psoriasiform lesion means it's like psoriasis. They have a similar histological feature. And there are three conditions which come under psoriasiform lesions, which has been an important MCQ. So please get familiarized with it and make a note of it in your keynotes. The three conditions that come under it is benign migratory glossitis, psoriasis, and Rita's syndrome. And another important feature about it is histologically, when you observe, there will be presence of a lot of micro abscesses, small abscesses, which a collection together is called as Monroe's abscess. MCQ, very important. Another thing that I want you all to do, everybody, is in your keynotes, all of you have a lot of space on the left hand side. I think it's a plain sheet for most of you. Write a box and make a note of conditions where you see Monroe's abscess. Okay? Write it as Monroe's abscess is seen in. Make a box of it. The first thing to go under it will be benign migratory glossitis, and as and when you come across conditions where you find Monroe's abscess, put that in that box, so that way you get a list of conditions where you see Monroe's abscess. That would be another activity for all of you. Please go back and do that. Familial dysautonomia means you don't have papillae at all. You don't have fungiform papillae and circumvallate. Not all papillae, but you don't have fungiform and circumvallate. Now, if you have to go back to anatomy and recollect what are the papillae which have taste buds in it. Yeah? It's the circumvallate papillae which has most number of taste buds, followed by the fungiform papillae. So when both these papillae go missing, finally the patient who's suffering from this has absolutely no taste sensation. So that's called as dysautonomia. Familial dysautonomia condition where there is absence of fungiform and circumvallate, where you see a loss of taste. That's because the taste buds are present in circumvallate and fungiform papillae. Dysautonomia. Anything that deals with the autonomic nervous system is dysautonomia. Here we are dealing with the autonomic nervous system, and any disease that is dealing with the ANS, or rather improper functioning of lack of function of the ANS, will be dysautonomia. Alright? Proceed. Next is hairy tongue, which is also referred to as the black hairy tongue. What happens in this is you have hypertrophy of the filiform papillae. Again, MCQ. We have previously seen conditions where filiform papillae go missing. Can you tell me the conditions where filiform papillae were missing? Absence of filiform papillae. BMG I think is benign migratory glossitis. Okay. What is MRG? Median rhomboid glossitis, geographic tongue. Yeah. Now these were conditions where your filiform papillae was missing. Now we are dealing with a condition where the filiform papillae are hypertrophied, increased. You find long. Normally they say that the filiform papillae is just about 1 millimeter in length, but here they become about 15 millimeters long. At least 15 millimeters long. That is the extent to which they can hypertrophy. And over here you have a lack of normal disc formation. It's common in males and HIV patients, which is again an MCQ. You will frequently find patients with HIV suffering from hairy tongue. And a patient who's consuming a lot of antibiotics is also prone to developing hairy tongue. And it's important that you don't get confused with hairy leukoplakia. They are two different conditions. Okay, hairy tongue common in males and HIV patients. Lingual thyroid nodule, again you must be familiar with how the thyroid gland is formed, right? And you know that when the thyroid gland is formed, in order to actually occupy its original position, it has to descend down. There has to be some amount of descent. And when this thyroid gland, it fails to migrate from its from the position near the tongue to its original position, you have a part of the nodule retained behind near the tongue. That's called as the lingual thyroid nodule, where some amount of follicles of the thyroid will be found in the tongue, and this is because of the failure of the thyroid to migrate down. That's lingual thyroid nodule. Then we have reactive lymphoid hyperplasia, which is basically, it's a simple, you can understand from the word, self-explanatory. It's hyperplasia of the lymphoid glands. And more commonly, it's the lingual glands that are involved, the lingual lymphoid follicles. Lingual tonsil hyperplasia is also called as foliate papillitis. Just get familiarized with this term. Kimura's disease. Nice term there. You have Kimura's disease. Now what is it? There are two things that is involved in Kimura's disease. Can all of you hear me? Are you able to follow me? Okay. There are two, let's say, organs involved over here. One is the vascular supply and the next is the lymphoid areas. So we have two structures. Overall, the blood vascular supply, blood vessels, and lymphoid tissue. So what you have is in the vascular endothelium, you have eosinophil multiplying. You're going to have eosinophils in the vascular endothelium and hyperplasia of the lymphoid tissue. That's all is Kimura's disease. I hope you understood it. It is hyperplasia of the lymphoid tissue with eosinophil infiltration. You will find eosinophils in the vascular endothelium as well as eosinophils in the lymphoid tissue. So overall, there are a lot of eosinophils. This is again a chronic inflammatory disorder. So you have eosinophilic folliculosis, eosinophilic lymphoid granuloma, angiolymphoid hyperplasia. So you find a lot of eosinophils. Then we have something called as Felty syndrome. What is Felty syndrome? It's got to do something with rheumatoid arthritis. In this, it's triad of features again, where you have rheumatoid arthritis, splenomegaly, granulocytopenia. Then coming to a term called atresia. Atresia is has been asked as MCQ, so please learn this term well. Atresia means when you don't have a duct of the salivary gland. All of us know we have salivary glands and they are duct containing glands. You have a duct through which the secretions come out. When the duct goes missing, that is when we call it as atresia. Gland is there without the duct. Gland is present but without the duct. So absence absence of or occlusion of a salivary gland duct is atresia. This has been asked as MCQ, so be sure of that. Then we have something called as aplasia. Aplasia of salivary gland means absence, agenesis, or rather there is no gland. So absence of a group or a single salivary gland, it can be unilateral or it can be bilateral, is called as aplasia. Now this can be associated with two syndromes. I just want you to get familiar with these two syndromes. It's called as LAD syndrome and mandibulofacial dysostrosis, which is your Treacher-Collins. Treacher-Collins, we will be studying it in detail later. I'll just tell you a little about LAD syndrome. L-A-D-G. The first letters itself are quite easy. L will be for lacrimal apparatus, A will be for auricles, D for dental defects, and one more D for digital defects. Can you all follow me on this? Okay. L-A-D-D. L stands for lacrimal apparatus, A stands for auricular defect, D stands for dental defects, and one more D stands for digital defects. In lacrimal apparatus, what do you have? It's affecting the nasolacrimal duct, so there is epiphora. Epiphora is a new term for you, important one again. Epiphora means excess of tears, overflow of tears, बहुत ज़्यादा पानी. Overflow of tears is epiphora. And another term called lacrimal sac inflammation called dacrocystitis. This has also been an MCQ in ComEdK as well as in Karnataka State Entrance. Epiphora has also been a question. Dacrocystitis has also been a question. What do you mean by dacrocystitis? It's inflammation of the lacrimal sac. Epiphora means excess flow of tears, which can happen because of compression of the nasolacrimal duct or obstruction of the duct. These are the problems with the lacrimal apparatus. LAD syndrome is again an autosomal dominant disorder. So we have one more syndrome that goes into your list of autosomal dominant. A, I told you, is auricular defect. You have deformed auricles which have a cup-shaped appearance. And please, all of you can make a brief note of this in your keynotes. It's not there in the keynotes, so please mention it in the keynotes. New students want this to go into your books. Dental defects, where you'll have peg-shaped defect, enamel hyperplasia, and hypodontia. One more D, which stands for digital defects, will have something called as clinodactyly. What do you mean by clinodactyly? There is a deviation of the fingers either medially or laterally. So they're not straight like this, they will be medially or laterally deviated. That's called as clinodactyly. LAD syndrome could be an MCQ. Mention it in your keynotes, it's not there. It's also there otherwise in your Schaefer. Then we come to aberrancy. Aberrancy means any defect of the salivary glands, where you can have an ectopic salivary gland, as in an extra. See, actually speaking, it's difficult to define aberrancy. Because in your entire oral cavity, you have a lot of ectopic salivary glands that are present. Ectopic means what? Presence of a salivary gland other than its normal position. Like for example, we say submandibular salivary gland has to be present in the submandibular fossa. Sublingual is going to be occupying a lower position. Parotid is meant to be here. Now apart from this, if you have these glands present elsewhere, it's called ectopic. Ectopic means other than its normal position. Now, you have a large number of salivary glands. Other than the major salivary glands, we have major salivary glands, which is your parotid, submandibular, and sublingual. But other than this, you have numerous minor salivary glands, like your anterior lingual glands, your posterior lingual glands, you have palatal glands, you have submucosal glands. So you have numerous minor salivary glands. Apart from these minor salivary glands, if you find that a salivary gland is present far away, okay, very far away from the normal structure, then we call it as an aberrancy. It's presence of ectopic salivary gland. And I come to Staphnase bone cyst, which is an important thing. All the other names of Staphnase bone cyst is important. It's also called a static bone cyst, lingual mandibular bone cavity, or latent bone cyst. What is it? It's basically the presence of a salivary gland tissue in the body of the mandible. Okay, we always talk of salivary gland being outside, right? But can we have a salivary gland within the bone? No. When we have it within the bone, we call it Staphnase bone cyst. Again, it has a very specific position. The position of Staphnase bone cyst is a very important MCQ. Where is it situated? It is situated between the mandibular canal and the inferior border of the mandible. For this, I want all of you to draw the mandible in your book. In your keynotes, or be it in your Pulse or in your Gauri Shankar, make it a habit to draw. This will be your mandible. Here runs your mandibular canal. Your mandibular canal is where you have the inferior alveolar nerve passing through, right? Now, this is situated between the mandibular canal and the inferior border of the mandible. So this is your Staphnase bone cyst. It's below the mandibular canal, which is a very important MCQ. This has been asked many times. It's very confusing, so please read carefully. Draw the diagram if you need. Now, this cannot be histologically differentiated because when you see a specimen histologically, it appears like a normal salivary gland. And no treatment is needed because it doesn't cause any harm. And there's another cyst called as a traumatic cyst. It's important for you to differentiate traumatic cyst from Staphnase bone cyst. Okay? Traumatic bone cyst is found above the mandibular canal. Staphnase bone cyst is found below the mandibular canal. We have a diagram. All of you can see the mandible, right? And we have the mandibular canal in the center, which is a red color thing. Below that, below your mandibular canal and between your mandibular canal and the inferior border is your Staphnase bone cyst. Above it is traumatic bone cyst. Now this diagram has to go into your books. With colors, without colors doesn't matter, but this has to go in any book you want. We have some term called as caliber persistent artery. There's not much I have to tell about. It's usually all of us know, no? All arteries are deep-seated. Major arteries. They find a deeper position in layers, right? Now what happens is when these arteries thicken and they become superficial such that you can even palpate them. That's called as a caliber persistent artery. It's like, for an example, labial artery. Okay, it's not like you can palpate and say, oh, this is labial artery. It's not so superficial that it can be palpable, right? It's deep-seated. It's found, maybe you have skin, you have your investing layer, you have your muscles, and maybe somewhere within your muscles you will have your labial artery. But in this disease, what is happening is your artery is getting thickened. The walls of the artery are getting thickened. And it's not like they are moving in position. Because of thickening, they are extending and becoming more superficial such that they become palpable. That's called as the caliber persistent artery, and this is very common in the lip mucosa. It's almost exclusive on the lip mucosa. So the artery that is most commonly affecting is the labial artery. This is the most common artery that it affects. So this could be an MCQ. This is how it looks. If you see in this diagram, see, normally you wouldn't expect, if all of you can go back and see the lip, maybe you can see veins. They're superficial, but you don't really expect to see an artery there. But you see here, you can see the slight thickening there. I hope all of you are able to appreciate the thickening. It's making that artery slightly palpable. And if you see a histology, this is not normally where you would find the blood vessel. Histologically also you will see a thick blood vessel. Imagine the thickness of this blood vessel. That's a caliber persistent artery. Okay. Let's just take a short break before I start off with the next part.